From the News Channel 5 Network, this is Medical Mondays.
Good evening, everyone, and welcome to Medical Monday. I'm Carrie Sharp. Thanks so much for choosing to be with us tonight. Great topic on board tonight, and I'm hoping that we can answer a lot of your questions. We're talking about hip and knee replacement, and I know if you're contemplating that, you probably do have some questions, and you're probably living in pain, so you want to get out of pain. So if you have a question about hip or knee replacement, go ahead and give us a phone call. The number's right there on the screen. 615-737-PLUS is the number to call. We have producers in the back, and they'll get your phone calls lined up, and we will take just as many as we can on the air. Let me introduce you to the doctor we have here tonight. Dr. Rory Sandberg joins us. Thank you for coming in.
Thanks for having me.
You're a little bit new to town, have a practice. Tell people about your practice.
Sure. So the practice is called Pinnacle Surgical Orthopedics. Right now it's a two-man operation with myself and Dr. Kaminsky. I subspecialize in treating all of the disorders of the hip and knee, specifically in the patients as they age. So I kind of say over 40 or so tend to be a little more of the degenerative conditions of the hip and knee, and that's what I focus on treating. And then we also treat everything of if you've had a joint replacement and it's gone bad, it's not working, there's concerns, you still have pain, trying to be a one-stop shop for all things hip and knee.
What made you interested in hips and knees?
It's funny. The orthopedic surgery training is 5 years of training,
wow.
And after my third year, I was kind of disillusioned with a lot of it. Honestly, I wasn't enjoying much of it. Hadn't done my joint replacement rotation, and started in on that, and was with a doctor named Dr. Miller, who's in Tucson, Arizona, where I trained, and he just did some really great work and helped a lot of people and had good results, and he took care of some of the things that not a lot of other people wanted to touch because they were afraid it was too risky or too hard, and it just really inspired me. It really rejuvenated my enthusiasm for orthopedic surgery in general.
It's a very cool story. I appreciate your honesty about that. Let's talk about when people find their way to your office and in need of help, what kind of condition are they in? What's your typical patient?
Typical patient, I mean, it really varies. There's some everywhere from a weekend warrior type that injured their knee or their hip, they thought they pulled their groin, and really when you start looking at it, it's early arthritis. And so we see everything from people that have had their first flare-up that really just need to be worked through non-operative steps appropriately, all the way up to we've had people that have had 2 or 3 joint replacements, wow. and they're still not working right, or there's a problem, and then they come in looking for help. So really it does run the whole spectrum of conditions that we end up seeing.
And hip replacement, at least, I think I read 120,000 per year in the U.S.
It's a lot.
Yeah, it seems like it.
It's a lot of replacements, and knees are becoming even more popular than the hip replacements in that regard. With the aging population, the baby boomers moving into retirement, we are finding that these surgeries are being performed at a ever-increasing rate.
Is it because the baby boomer population is becoming bigger and also we're more active?
That's a large part of it, and as our understanding of joint replacement has gotten better, we have better materials, we can perform them safely. I think in the younger, more active patient that maybe traditionally you would have tried to push off several years and say, well, you're too young for a knee replacement, but now, you know, it's fairly common to be doing joint replacements in somebody in their mid-50s.
Yeah. You brought some models here with me, and I love show and tell. Can you tell me what we're looking at here?
Sure. The first model that we have here is a representation of a total hip replacement. So this is the pelvis bone, this is the hip socket, this is the femur, the top part of the femur, and what this shows is really what the components of the hip replacement entail. So in a hip replacement, it's the joint that's gone bad, and so we actually will take a saw and we will cut the top part of the femur where the ball usually is, and that goes to the pathology department. And then with this see-through model, you can see that we actually put a stem down in through the center of the bone. It's hollow, almost like a piece of PVC pipe. And that has a very tight interference fit, we call it, and it has a surface that the bone will actually grow into. It's a roughened surface. And then we do the same thing on the socket side, where we actually will mill out the appropriate size hemisphere, put this cup in, and then we put a ceramic ball and a plastic liner. We put the hip back together, and instead of having painful bone rubbing on bone, now you have ceramic or sometimes metal rubbing against plastic.
I want to talk more as we go throughout this next hour about recovery and how quickly people are back on their feet and complications from this surgery. But needless to say, this is a big surgery. This is a big decision.
It is a big decision, and it's one that you have to make after you've heard all the risks and the benefits, and you make it most of the time at the consultation with your physician and your family. But that being said, these are not the same surgeries that were done 20, 25 years ago. As a surgeon community, as really a hospital community and a healthcare community, we've gotten much better at administering this excellent treatment to where it's not quite the negative impact in your life that it had previously been, where you're spending days in the hospital and it's weeks and weeks and weeks and weeks of recovery. The process has become quite streamlined.
That's amazing. Has the prosthetic itself changed a lot over the last decade or two?
I mean, it has changed to some degree. Some of the materials that we've made for the bone to ingrow into these surfaces have gotten better with some advances like 3D printing and just the understanding of what makes a good fit for that bone to grow into. So that has definitely helped. Traditionally, the hip replacements for many, many years used cement to fix the pieces to the bone. And many people still use cement, and I'll use cement in certain situations, but more and more, as more data has come out and the advances in the technology, we're finding we can get away more with these, what they call press-fit implants that grow into the bone.
It's very interesting.
Or rather, that the bone grows into.
Wow. Okay. I always say on Medical Mondays, we're going to take as many questions and calls as we can, because this show is about you. And I know I have, let's see, it looks like Lee is on the phone. Hi, Lee. Do you have a question for us tonight? Lee, you with us? They sure did. Okay. Well, Lee, hope you call back in if you get a chance. In the meantime, I'll just keep answering the questions or asking the questions. Dr. Sandberg will answer them for us. 615-737+ is the number to call. So we've talked about the hip a little bit. You also have a knee over there.
I do. So the knee replacement, similar principles. The knee's made up of 3 bones. The lower part of your thigh bone called the femur, the top part of the shin bone called the tibia, and then the kneecap also called the patella. And we think of the knee as having 3 different areas or compartments. So the inside part, what we call the medial, the outside part called the lateral, and then this front part of the patellofemoral joint. And so all of these need to be resurfaced as well. So in the knee, what's a little different is you really only take off about 1 centimeter of bone off the lower end of the thigh bone and the top part of the shin bone, and sometimes off the back of the kneecap. And then it's really a resurfacing. So instead of that painful bone, you put a piece of metal on both the tibia and the femur, a plastic shim almost in between the 2 of them, and then a plastic resurfacing on the back side of the patella. I will say that this is one that has more traditionally been done in North America. In Europe, this is not traditionally done, and there's more and more data that has some of us in North America questioning how often we actually need to resurface the back of the kneecap. So a lot of people are moving to a selective resurfacing of looking at it in surgery, taking into account age, size of the patient, how bad the bone looks, and maybe we're not resurfacing as many as we used to.
It's so interesting because really you are rebuilding that portion of the body and giving a patient a new knee or a new hip.
Well, in many ways that's true. And what's interesting that we tell people, though, is that as great as these advances are, this never replaces what you were born with. And so I think it's one of the biggest misconceptions we have is the term of, while it is a new knee in the sense that it's new to you, it does not feel like the same knee that you had when you were 20, for example.
Right.
In most cases, it's a replaced knee. It will feel a little different. The whole goal is to have it be a better knee that's less painful and functions at a better level than your previous one did.
That's a good point. I hadn't thought about that. Is it arthritis that brings a lot of people in?
A lot of times it is. There are some occasional conditions in the hip where in the native hip, the ball portion can actually have a disruption to its blood supply and the bone can die. You know, sometimes we see conditions called dysplasia that is kind of a malformed hip, but most of the time it's run-of-the-mill, what we call wear and tear osteoarthritis, that over time the cartilage has just worn down, almost like the tread on the tires wearing down. And as that happens, it becomes painful as the bones start to rub against one another.
Okay. Very good deal. We've already learned a lot in this first portion of our hour here on Medical Monday. When we come back, your questions, hopefully, for Dr. Sandberg. I can see we have plenty of folks calling in on the line. Still a few lines open, though, so if you have a question, call us during the break, and we'll get that set up. We're coming right back with more on Medical Monday.
At Cigna Health Spring, we have one priority, you. So when you're looking for the right Medicare Advantage plan, we partner with you every step of the way. Cigna Health Spring Plus You means our plans are designed around you with an approach to healthcare led by your doctor. Call Cigna Health Spring now to learn about your options and get a free guide. There's no obligation. Cigna Health Spring puts you first with plans that offer no monthly premiums, no primary doctor copays, prescription drug coverage, even dental and vision services. With a Medicare Advantage plan from Cigna Health Spring, you'll enjoy one more advantage, a focus on preventive care designed to help you stay healthy. Medicare open enrollment is here. Choose a partner that puts you first. Cigna Health Spring. Call 1-855-707-7179. That's 1-855-707-7179. Cigna Health Spring. Together, all the way.
Staying healthy is on everyone's mind. Dr. Sean Pruitt has spent his career in medicine, dispensing expert advice and helping patients get on the road to recovery. Now Dr. Pruitt is here to help you. Introducing Pharmacist on Call on News Channel 5+. Don't miss your chance to get free advice. Watch Pharmacist on Call with Dr. Sean Pruitt the second Thursday of every month at 7 p.m. on News Channel 5+.
Your day moves by pretty fast. Chances are you missed something.
Before you call it a night, let us catch you up on everything you missed and get you ready for a busy tomorrow.
Watch News Channel 5 at 10. Then rest easy
knowing the last word on everything that happened today and feeling ready for whatever happens tomorrow.
Get the last word on everything new.
Watch News Channel 5 at 10.
This is my new best friend, Esther. She might look like any normal, playful puppy, but Esther's being raised to become a canine companions for independence assistance dog for a person with a disability. To get there, she needs lots of loving care and attention, plenty of exercise, and good eating habits so that she can live a long and healthy life for her future family. Visit cci.org or call 1-800-572-BARK. Raise a puppy, change a life. You can make a world of difference in the life of a person with a disability.
This is the safety cage that protects you and your family in a collision. When insurer body shops use imitation aftermarket parts to save money, you could lose more than your car's value. This is why Price's Collision always recommends original quality parts. It's why we are certified with so many manufacturers. Since you have the right to choose, why not choose the best repair from
Price's Collision, a perfect repair with a lifetime guarantee.
Welcome back to Medical Monday. We are talking hip and knee replacement with Dr. Rory Sandberg. Thank you for being here once again. We do have some calls tonight to get to. As always, we'll jump right to him. Kenneth is on the line. Hi, Kenneth.
Hi.
Hi, go ahead with your question.
When I was 12 years old, I had 3 pins put in my right hip because of the pelvis and the joint wasn't fully developed for that age. I had the pins taken out later on when I was 17. I'm now 58, and the hip is worn, and I can see a possible hip replacement later on. My question is, when I was 12 years old and they put the pins in, it stunted the growth of the hip, the leg length. My leg's about 1.5 inches shorter than the left one. Is it possible when they put the implant in there, can they lengthen this leg and make it the normal length as the other?
What an interesting question. That would be life-changing, I'm sure, in some aspects.
Yeah.
Can you do that?
Well, so, Kenneth, I would preface this by saying without actually seeing the x-rays, I think I'm following well enough to understand what the situation was. Without seeing the x-rays for sure and seeing exactly how much of a leg length discrepancy there is, I'm not sure. Typically, when we do a hip replacement, we do gain a little bit of length in that hip, just by nature of kind of retensioning some of the muscles in order to keep the hip stable. That being said, to overcome an inch or so deficit would be pretty hard to do with just a standard hip replacement.
Okay. All right. Well, you answered my question. I appreciate it.
You're
All
welcome.
right, Kenneth, thank you for calling in. We also have Lee on the line. Good evening, Lee.
Oh, yes, I appreciate you taking my call.
Sure thing. What's your question?
Well, just to give you a quick overview, without taking too much time. I'm 64, I'm disabled, and I've got knee and hip problems for a long time, and also it goes down to my foot. But the question I had here is, I really don't know what to do. Now, I've had one x-ray on my knee, no MRIs, and I do have a lower back L5 or 6 from birth that's degenerate. And I'm trying to get information on what I should do. You know, I'm going to have to go to an orthopedic because it's gotten so bad now, so severe. I'm in chronic pain. I'm taking, pain medication just out of the guru. Anyway, it's getting so hard where I can't walk very well. I can't cook. I can't hardly do anything because all my focus is trying to minimize the pain.
Right.
And so I just wanted to hear what the doctor had to say and whatever.
Sure.
Also, I wanted to know if I do need a knee or hip replacement. Would he recommend both of them done at the same time?
You know what? That's a great question because I just asked it, so I'm going to say it's a great question. But we'll let Dr. Sandberg ask it.
So thanks for calling, Lee. So to answer the last question first, you shouldn't have a hip and a knee replacement done at the same time. When I hear someone that's saying that they're having pain in their back, in their hip, in their knee, all the way down to the foot, typically that's something that we think more of spine pathology. And I know you mentioned you had a disc, I think you said, at L5, and that can also cause pain where it's difficult to walk, can sometimes cause numbness, tingling, chronic pain like you're talking about. When we talk about arthritis in the hip, sometimes you can have pains that radiate down to the knee, but it's very rare that you have any pain that moves past the knee down into the feet and toes. So to me, if Lee was in my office, the first thing on my mind that I'd want to do is see what his spine looked like, because that sounds a little more like what the pathology is. Now, that being said, people can certainly have spine disease and hip arthritis and knee arthritis, and then it becomes up to us as a physician to try to delineate, well, which of those is the most symptomatic.
Right.
And there's different things we can do. We can do things called diagnostic injections where we select a certain area, either the knee, the hip, or the spine, inject a little numbing medicine in that area, and then have you walk around, and we say, how much better is your pain? Is it 0% better? Is it 50% better? 100% better? If we inject your hip and 100% of your leg pain goes away, well, then that's probably your pain generator, and you would do well with the hip replacement. If we inject your hip or your knee and you say, that didn't do anything for my pain, then a joint replacement wouldn't help you. So the first step would be to try to just get evaluated by an orthopedic surgeon, look at all of these issues, and really try to delineate what's your pain generator.
And going in for that first appointment, he should expect an x-ray, MRI. What would you do?
Yeah, typically if somebody like Lee came to me, I would start with x-raying the hip. Depending on how bad the knee was, we'd probably get x-rays of the knee as well. Depending on what those looked like, we may then get an x-ray of his lumbar spine. If you want to talk about MRIs, the only MRI that would be of utility, I think, in his case, depending on what his x-rays looked like, would be an MRI of his spine. So typically, once somebody has arthritis in their hip or their knee, you don't really need an MRI to give you any more information. It's like zooming up on worn-out tread on your tires. You don't gain any additional insight. You know it's worn out. So figuring out every little tear and nook and cranny that's worn out on the tire tread doesn't help you solve the puzzle anymore. You have to replace the tread on the tires. So MRIs for arthritic hips and knees that already show arthritis on x-ray, probably not a whole lot of use for that.
Well, it's kind of good news. It saves a little money, too, in the long run.
It does.
I mean, not having to go for that MRI. Let me ask you this also. So many doctors seem so specialized these days that sometimes if you don't know exactly what your problem is, it's hard to know where to go. So you said that you're a hip and a knee guy. He maybe has a spine problem, but maybe a hip and a knee problem. Where does he start?
The short answer is that you can really start with either of them.
Because you're an orthopedic surgeon.
We're both orthopedic surgeons. Typically, spine surgeons can either go an orthopedic surgery route or a neurosurgery route, but we're very used to having crossover patients, meaning in my hip clinic, it's not uncommon for me to see somebody that has lumbar spine disease. And so if I find it, we're tuned into the differences in the symptoms. We then refer them on to the spine surgeon. And likewise, if a spine surgeon has somebody coming in for low back pain or buttock pain that their primary care doctor thought was sciatica, then if they do an x-ray and move their leg around and say, this seems more like hip arthritis, well, then they'll send them over to me.
Gotcha.
So the good news is that in some ways Lee can't go wrong.
Yeah.
He can go to either place and they'll probably be able to help him get where he needs.
Good. That is some good news. And I was asking you during the break, if somebody has either, one side hip replaced or one knee replaced, does it mean down the road that the other knee will go bad? Is there any correlation whatsoever?
There's not 100% correlation. We do tend to see there is some evidence coming out that shows some maybe familial clustering of arthritis. There were some studies done in Utah that showed there was maybe a genetic component to osteoarthritis, and we certainly see that if somebody has a hip or a knee replacement a few years later, you end up replacing the other knee or the other hip. But it's not always. Sometimes people do just have one that goes bad. Maybe they had a trauma to it at some point, and that's what started the whole process. And then they end up just having one joint replacement, and that's all they ever need. So I would say it's highly variable.
Okay, good info. Let's go to Ida. She's on the line, waiting ever so patiently. Hi, Miss Ida.
Hi, how are you?
Good. Go ahead with your question.
I want to know, okay, I have the arthritis, it's the degenerate arthritis in my knee. And I had a MRI done, and he said that I wasn't bone to bone yet, but I have so much pain in it and stuff. So if I have a knee replacement, would that help with the arthritis, regardless whether I'm not bone to bone or anything?
So this is a good question that we see a lot. And again, it's hard to say for sure without having more time to ask her more questions, examine her, and exactly see what her imaging is. But one thing we do know is that patients' pain does not always correlate with how severe their x-rays are or their other imaging studies. Meaning, I've seen patients that have terrible looking x-rays and they function rather well. And likewise, I see patients that have some arthritis, maybe not quote-unquote bone to bone, but they're debilitated. And so what we try to do is treat the patient and not treat the x-ray. And so it would be some additional questions I would like to ask that patient, see what other treatments she's tried. But certainly we've done joint replacements and knee replacements in patients that maybe were not quite bone to bone, but were severely debilitated, and they have an arthritic process that would benefit from a joint replacement.
Hopefully that answers your question, Ida.
It did. Thank you.
Thank you for calling in.
Thank you.
Let's talk about when a patient comes in and they're maybe not ready to make the jump to I need a replacement right now. Where do you start when someone is in pain?
So when someone is in pain, I think one of the biggest things that we can do as physicians and especially as joint replacement surgeons is to try to empower the patient and say, look, this is an elective surgery. So the concept of somebody needing a joint replacement, I would say, is a very slim margin of people that actually need a joint replacement. So it is a quality of life decision that you have to decide, how much is my pain interfering with the activities that I want to do? And I use the example a lot of a ladder. So if you need to change a light bulb in your house and you can change that light bulb effectively from the second rung of the ladder, well, there's no reason to climb to the sixth rung to change the same light bulb. You just introduce more risk into the scenario. But if you can't change the light bulb from the second rung, then maybe you do need to go up some more rungs on that ladder. And treatment of arthritis, whether it's in the hip, the knee, the elbow, is pretty much follows those same principles of you start and say, okay, well, what activities can you modify? If somebody comes to me and they say, my knee only hurts when I play golf, and I hate playing golf, then guess what? Your treatment of your knee arthritis is you quit playing golf. You know, so there are lots of different things you can do. That's called activity modification. So how can you modify your environment? What things are you okay giving up with? If that same person comes to me and says, my knee only hurts when I'm playing golf, but I have to play golf, otherwise I'm going to be depressed and miserable, well, then we need to find a way to help that person play golf. There are medications that can be tried. There's home exercises that can be done, and the right types of exercise will rebuild the strength in the knee or the hip, and that can be quite beneficial in resolving some of the pain that people have. Injections are another steps. Certain types of injections work better than others. So there really is a decent number of non-operative things that can be tried, and it may not be the magic cure-all that cures your knee pain for the rest of your life, but it may save you 4 or 5 years. A case in point is my mother-in-law. She had some early arthritis in her knee, kept seeing doctors, couldn't get any relief. We put her on a home strengthening program to just do some daily exercises of her knee every day and use a stationary bike. And after 5 years of doing that, she still has never really sought out any additional treatment of her knee pain. It's helped tremendously. So sometimes just the simple things can actually have a big impact.
Do you call and check up on her? Are you doing your exercises?
I just saw her. She came and visited us last week, and I said, "How's your knee doing, Misty?" And she said, "You know, I still don't have any pain in it anymore. I keep doing my exercises." So that's her treatment for her arthritis.
Very good. Okay. When we come back from commercial break, we'll talk about when people do need to make that jump to hip replacement or knee replacement, what to expect in surgery and after. So stay with us, and if you have questions, go ahead and give us a call. We're coming right back.
This is a Storm 5 HD weather.
Widespread freeze and frost conditions across Tennessee and Kentucky this morning gave way to a really beautiful day. Sunshine, blue skies, temperatures climbing into the 50s and 60s across the area because we've had enough cold nights, cold enough to prompt freeze and frost conditions. We won't have any more freeze or frost advisories issued until spring of next year. That doesn't mean it's not going to be a cold night. It just means the damage has been done to the growing season. Here's a look at temperatures across the southeast and, of course, current conditions right here in Nashville. Overnight tonight, we dropped down to 39, so not quite as cold as it was Monday morning, but that's still plenty brisk. Cooler than that outside the city, down to mid-30s in some spots. Tuesday looks mild and barely so. We'll have cloudy skies, temperatures in the upper 50s. Things look good for trick-or-treaters, a little cool with the extra cloud cover. Then rain will work in overnight Tuesday. By Wednesday morning, we'll have scattered showers across the area.
The hidden dangers of coffee makers.
Oh, my God. Are you serious?
Yes.
Next, Inside Edition. What may be lurking inside your coffee maker? You'd be surprised. Inside Edition puts coffee makers to the test.
Oh, wow. It's really shocking.
Then, the new Tonya Harding movie. It makes her mom the villain. What Tanya's real mom has to say about that.
I had nothing to do with that.
Next, Inside Edition.
Tomorrow at 4:30 on News Channel 5.
The body, it is a work of art and a powerful ally in the fight against cancer. A new approach called immunotherapy works by helping our immune system correctly identify and eradicate many types of cancer cells. Speak with your doctor and visit su2c.org/immunotherapy to learn more. Your body might just be your greatest hope.
Welcome back to Medical Monday. If you're just joining us, we're talking about hip and knee replacement. Dr. Rory Sandberg is here. Thank you for being with us once again. Learning a lot here in this half hour so far. We have another half hour to go, so that means plenty of time to call in with your questions. The number is on the screen, 615-737-PLUS. Let's jump to Ann. She's on the line. Ann, thank you for calling in.
Yes. This is Ann.
Yes, hi, Ann. Go ahead with your question.
Okay, I want to know if he's ever put a half of a knee replacement in.
Yeah, so good question. Called a partial knee replacement.
Okay.
Yes.
I do perform partial knee replacement surgery, and it's actually a really good surgery in the appropriate candidate.
Okay, who would that be?
So the appropriate candidate for a partial knee replacement is somebody that on X-ray has the majority of their arthritis in one location. We talked earlier about how the knee has 3 different compartments. So if the majority of their arthritis is located to that one compartment, and that's where the patient is symptomatic, meaning that they have arthritis in one location, but they don't say their whole knee hurts. They say it hurts right in this location where the arthritis is. That's a really good candidate for a partial knee replacement. And the outcomes are really quite good. They show that partial knee replacements versus total knee replacements in the right candidate, the partial knee replacements can have a quicker recovery, and they have a higher patient satisfaction than the total knee replacement. But I can't stress enough that the right candidate is important. And in the orthopedic community, we're still trying to delineate who that right candidate is. There are some surgeons that accept a little more arthritis in the other compartments than others. Where I trained, we were pretty stringent on arthritis in one location and having the symptoms in that location. And when we did that, we had very good results with our partial knee replacements.
So you're saying you try to keep it pretty black and white, but in other places it gets a little gray.
I do. Where it gets a little gray is sometimes under the patella, so under the kneecap. There's variable amounts of data showing, you know, how much arthritis can you accept under that kneecap and still get away with a partial knee replacement. This is an evolving area, and I don't know that there's a good answer for that yet, because certainly I've seen patients that have a partial knee replacement with a decent amount of arthritis under that kneecap, and they love it. They're functioning great. So it's still kind of an emerging area in terms of who the exact best candidate is.
Okay, Ann, thank you for your call. We appreciate that. Great call tonight. I do want to talk about the folks who have decided, yes, I need a joint replacement, whether it be the hip or the knee. And these answers may vary a lot depending on what joint it is. But what do the surgeries look like, as in the amount of time spent on the operating table? And then let's talk about recovery a little bit.
Okay. So time spent on the operating table can be a little variable. I tell patients it's anywhere from an hour to an hour and a half as just kind of a ballpark for a hip or a knee. The surgeries themselves, I mean, you can look at them on the internet and on YouTube. They're not for the faint of heart to look at. They're pretty open surgeries because we have to see things clearly enough to get the implants in. That being said, we do much smaller incisions and exposures than they did when the surgeries were first brought into the field, but it's not the same thing as having an arthroscopy. They're usually in the hospital overnight over at the Summit Hospital where I practice, and most patients are able to go home that next day after surgery. Sometimes they need to stay a second night, but we really try to make a conscious effort to get patients home and get them home safely within a day or two. The day of surgery, we have physical therapy that sees people twice a day, so you actually get up and walk the day of your surgery for a hip or a knee. We found that these rapid recovery protocols really do a lot to help people have the best outcome with their knee or hip replacement. And after that, it's just kind of a recovery process. For the hips, I don't send my hips to physical therapy. It's really just a matter of getting up and walking. For the knees, we do some type of physical therapy for 2 to 4 weeks.
Is it basically to get the motion back? What is the physical therapy or the exercises all about? Go ahead. If you need your water, go ahead and grab it. No problem. It looks like we have some callers coming up on the line. So if you guys want to tell me the callers' names, I will get those written down and we'll take that. But until you guys, our producers, when I say you guys, I'm talking to our producers. Until I hear those names, that's okay. It happens to the best of us. We'll talk about just when it comes to the hip or the knee. You mentioned that the hips usually can go home, which is great, but are there restrictions at home and things that people need to be advised about, like getting in and out of the shower, that sort of thing?
They do, and hips especially. There are some restrictions.
You know what? Let's take a quick commercial break. We'll give you time to recover, because I've been in this situation before, and it's miserable when you just need a good cough. So we're going to take a quick commercial break. When we come back, more of your questions, more of my questions. We're coming back on Medical Monday.
At Cigna Health Spring, we have one priority, you. So when you're looking for the right Medicare Advantage plan, we partner with you every step of the way. Cigna Health Spring Plus You means our plans are designed around you with an approach to healthcare led by your doctor. Call Cigna Health Spring now to learn about your options and get a free guide. There's no obligation. Cigna Health Spring puts you first with plans that offer no monthly premiums, no primary doctor copays, prescription drug coverage, even dental and vision services. With a Medicare Advantage plan from Cigna Health Spring, you'll enjoy one more advantage: a focus on preventive care designed to help you stay healthy. Medicare open enrollment is here. Choose a partner that puts you first. Cigna Health Spring. Call 1-855-707-7179. That's 1-855-707-7179. Cigna Health Spring. Together, all the way.
Country Inns and Suites in News Channel 5 are proud to put Military First this Veterans Day. Go to newschannel5.com/Military First and nominate a deserving service member or veteran for his or her chance to win $1,000 and 2 free nights at Country Inns and Suites.
Country Inns and Suites wants only the best for our best. That's why we launched the Military First program. It honors active service members, veterans, and their spouses with a preferred rate, the best available room at the time of check-in, and more. For more information, visit countryinns.com/military.
So, same time next week?
Well, of course. Put away a few bucks, feel like $1 million. For free tips to help you save, go to Feed the Pig.
Back to Medical Monday. I'm here with Dr. Rory Sandberg talking about hip and knee replacement. Dr. Sandberg is an orthopedic surgeon, but this is your jam, is the hip and the knee.
It is.
All right. So I was asking before we went to break about hip replacement, and you said those folks tend to go home pretty quickly. Not a lot of physical therapy, actually, having to go to the physical therapist. You have them doing exercises at home. But what about things around the house that they need to pre-think before surgery?
Sure. Some of that has to do with just being able to do your activities of daily living, we call it. So going to the bathroom, getting things up off the floor in a safe way. We do have some restrictions that we put in place for about the first 6 weeks or so after surgery, just because the hip can be a little tenuous in terms of being stable in the socket. And it's stable when we leave the operating room, but we try to not have huge forces going in awkward angles across the hip because you could pop it out. So the first 6 weeks, we have people just avoid some certain movements with their hip that have to do with how far they bend down, what direction they twist their leg. But they're pretty simple to get to an understanding of, really. But really, most of the time, if people have somebody at home that can help them out the first few days, after that, they're on a walker for a few days, then they go to a cane, and then really just as more they walk, the more they build up the strength in their muscles, and the more they get back to doing the activities they want to do.
What is that time frame when people feel like I'm back to normal?
You know, that varies from patient to patient. There are some patients, I would say more so with the hip, that leave the hospital saying, oh my gosh, my hip feels so much better already.
Really?
Because this deep, achy front of the groin and hip pain that they have after hip replacement is gone. They have some pain from the surgery and from the muscles in the surgery, but they say it's a different pain. I can deal with this. Knees are a little different. Knees are harder to get over than hips. I tell people, on average, I say it's a 6-week investment surgery, meaning you still have some pain, probably more than you did before surgery, for the first 4 to 6 weeks after that surgery. You're taking pain medications, you're not sleeping that well, but that slowly gets better and better again. The more you go to therapy, the more your body just recovers from the hit that it took in the operation, and the more you get out and try to return to normalcy. By about 6 weeks, I say, though, is around the turning point for a lot of people, where they say, okay, I'm finally coming off the pain meds, I'm sleeping a little better, and my knee is starting to feel better than it did before surgery.
Why the difference? Is it because the knee is involved in so many more movements, or why? Are the surgery so different?
It's hard to know, because the knee, for some reason, it has a lot of pain fibers in it. Some think, that there's a thought that, the knee being much closer to the surface, people can see it, and it's just kind of a different beast than the hip, honestly. Some of it, too, is that the hip's a ball and socket joint, which tends to be a little more forgiving, I guess, in terms of the mobility that you need from it. But for whatever reason, the hips just do much better than the knees. Overall, kind of nationwide, the numbers they report that about 95% of patients are satisfied with their hip replacement and say that they would have it again, whereas for the knee, it's maybe only about 85% of people are really satisfied and say that they would do it again. So for whatever reason, the hip just is much more of a home run surgery usually than the knee.
When you're thinking surgery, you always have to think about complications. What do you warn your patients about?
So, depends differently from hip to knee, but unanimously we warn the patients about the risk of infection. As a surgeon, as a patient, that's one of the more devastating complications that you think about. If a joint gets infected, it's not the end of the world, but it is usually a couple-month process to try to treat that infection. It usually requires at least one, a lot of times 2 additional surgeries. It involves taking the implants out, putting temporary ones in made of antibiotics and cement, IV antibiotics, and then a second surgery to put a new implant back in once you've cleared the infection. So that's one of the big ones. The other big one for the hip is dislocation, as one of the ones you worry about the most, and so that's why, again, we have people...
That sounds terrible.
We have people avoid those positions for the first 6 weeks or so, but after that, once everything scars in, the dislocation risk is pretty low. I mean, for dislocation, we're talking about 1% or less of all cases, so it's not 40-50% of people that this is happening to. For knees, the most common complication after a knee replacement, I mentioned that 85% that are not quite happy with it, that's the most common complication, is persistent pain after a knee replacement. And we as a surgeon community are really doing our best to research and try to figure out why. I have a patient that it looked like they were a good candidate, the implants look good, the knee feels good, yet they're not happy. And everybody, that's where a lot of the research in knee replacement is going right now, is to try to figure out, why, how can you predict which patient may not be happy with their knee replacement after surgery? And
just so I make sure I heard you correct, did you say that 85% of knee replacement folks are happy? Is that 15%?
Yeah, and so it's about 15 or so percent. And again, that's kind of nationwide. 15% or so, they're not quite as happy as they wanted with their knee replacement.
Okay, very good. Let's jump to the lines. We have Shirley on the line. Good evening, Shirley.
Yes, I have a question about my knee. I have a torn meniscus in each side of my knee, and I want to know if it is more likely, if I don't have it repaired, am I more likely to need knee replacement as compared to if I do have it repaired?
Great question. Will it lead to other things?
So, I guess a follow-up question I would have if Shirley is still on the phone is, Shirley, may I ask how old you are?
81.
81. So,
yes.
I would preface this by saying I would need to see your x-rays, but if your x-ray shows some arthritis, that's really what those meniscal tears are. Is they're a manifestation of the arthritis. So again, going back to the tire tread example of once you've worn the tread on your tires, you're less concerned with every little flap and crack and tear in the tire tread. You have to think of it as a whole. And arthritis is very much the same. And what we've learned is that if we try to take a knee that has arthritis and do an arthroscopy to fix that meniscal tear like we would do in somebody that's 16, the data has been very clear that it doesn't really offer any long-term benefit. And in some cases, it makes the knee arthritis worse. So for somebody like Shirley, if she was in my office, again, if her x-rays showed some arthritis, I would not recommend an arthroscopy. I would say we try to maximize non-operative treatment if we can. And if that doesn't work, the surgery that she would need would be a knee replacement, not an arthroscopy at 81 years old.
Yeah. Very interesting. Shirley, I hope that helps clarify some things.
Okay, yes. Thank you very much.
Thank you for calling in. We also have Richard on the line. Richard, go ahead.
Yes. Let me just turn the
TV down a little bit?
Yeah.
Okay. Appreciate that.
I had a orthopedic surgery October 5th of last year.
Okay.
It was on my knee. It was arthroscopic, and it was for a torn meniscus. Shortly thereafter, I didn't injure it, but I was on my knees, and I got up, and when I got up, I couldn't put any weight on it. I went back to the doctor. Doctor says, you have a bucket tear. And apparently I'm trying to get the bone right. The femur has 2 knuckles on it for your knee, an outside and an inside. I guess they're called compartments. He said that the compartment on the outside of the knee is tore up. And I'm like, okay, a lot of arthritis. I'm 61. I've been offered 2 options, actually 3 options. The first one I turned down was a bone graft by the VA. The reason I turned it down, he said, I'm a bachelor. I live alone. I have no children. I have a 150-pound service dog. We just came in. He told me that if my foot hits the ground anytime during this 3-month recuperation, that I could lose the leg for damaging this graft. I told him no. Now I see another physician, Dr. Cox out of Vanderbilt, and he said, look, I'm not going back in there. I'm referring you to a guy for replacement in our team. I'm 61. I'm not an active guy. The most active thing I do is walk my dog. Now I'm like, okay, do I go with the partial or do I go with the full replacement? And what does all of this entail?
Okay, so that's where we are.
So thanks for the call, Richard. So Richard's scenario is one that we see on occasion. So again, he has more of the whole picture of arthritis, the chunks out of the cartilage that he talked about, again, a manifestation of the arthritis. So I would say what you decide to do, Richard, really comes down to how much pain you have and how your life is being affected by it. If you can walk your dog without any treatment, and that's what you want to do most, well, then you don't have to do anything. And I stress that again. These are elective surgeries to try to help you be more active and live life more pain-free. That being said, I would look at his x-rays. I would see what kind of treatments you have tried. If he was somebody that really wanted to avoid a surgery, I think that's totally fine. We could work on some home strengthening exercises, maybe do some cortisone injections. If none of that helped, I would offer him a knee replacement based on what he's saying. Again, I can't make the distinction as to whether or not a partial or a total would be better for Richard. I would have to examine him and see the x-rays. But I think either one of them would be certainly an option for Richard if he's really somebody that's uncomfortable and is unhappy with their quality of life.
So, Richard, after this commercial break that we'll take in a few minutes, you've got plenty of time to do this. Grab a pen and paper, and we're going to give you the number to call or the emailing if you want to get a hold of Dr. Sandberg and talk about some things and have him look at your x-rays. So you got several minutes to get that pen and paper, but go ahead and do it. We'll be giving out the email and the phone number in just a little bit. Let's talk about revision surgery. I'm sure that comes up from time to time. People have had a hip or knee replacement, and it's not gone so well, or there's been additional injury or additional aging. What sort of things do you see with that?
I mean, that's really to a certain extent a Pandora's box. I mean, it can be anything. I mean, it can be anything from just the plastic component in between just wearing out over time, and so we just need to go in and replace that piece of plastic in a hip or a knee, and then that's it, to everything from a big process where bone is lost and is eaten away, and you have to use much different implants, much bigger implants. It really runs the gamut. In terms of the knee, we see everything from components that have come loose from the bone, again, bone loss, infections, and sometimes where the ligaments or the tendons are torn away from the knee and you have to try to reconstruct those or put implants in that actually interlock one with another to provide that stability. So it really runs the gamut of what you can see and really what we can do. But that's part of what we're trained to do. Sometimes in the bigger revision cases, you're putting in a whole piece of metal that takes off the top half of the femur. You have to replace all of it because it's, the bone has been eaten away or there's some kind of a problem. Same thing with the lower half of the femur and a knee replacement. Sometimes after several revisions, if there's just not a lot of bone left to work with, you have to replace it with metal. Actually, in Nashville, there's a very famous implant that was developed actually here in Nashville by the gentleman at Southern Joint Replacement that dealt with big bone loss problems in the acetabulum. And every once in a while you have to get really creative like they did.
Wow, that's very interesting. How long are these prosthetics made to last?
Another good question. So more modern parts, for example, the knee, we're seeing 95% of the knee replacements we're putting in are going strong at 15 years. And so that doesn't mean at 15 years, oh, they all start falling out. Most of them are still in the patients and don't show any signs of any adverse wear or coming loose from the bone. Hips, they're about 10, 15 years ago, we redesigned, not we, but the biomaterial experts did some different things to the plastic liner. The plastic liner that we used to see, it used to make a lot of debris, and that would cause a big inflammatory reaction that would eat away the bone. But with this newer polyethylene, which is the name of the plastic, we're starting to see a lot less bone loss, and we're seeing the hip replacements just lasting longer and longer. And even if you do have to go in and replace that piece of plastic, you're not dealing with the bone loss issues that we once did. So it's definitely getting better as our materials have gotten better, and as we understand the processes that led to the destruction of the bone. Thankfully, we're not seeing as many of the big revisions with bone loss that we used to.
When you have a patient come in who is 40 or in their 50s, do you have different conversations with them because these are not made to last 40 years on what to do?
We will have different conversations a little bit. I think at that point, you know, if I have a patient that's 45 or 50, you know, I talk maybe a little bit more about the longevity of the implant and the possibility of a revision down the road maybe than I would for somebody that was in their 80s. But that being said, if they really are at the end stages of that disease, you know, they're not going to want to live the next 20 years of their life in pain just to avoid a theoretical revision down the road. So it becomes something that you deal with that scenario and you say, okay, down the road, when and if that problem comes, you know, well, then we handle it. Sometimes there are, you know, slightly different modifications in the implant and choices that you might make in a younger patient in terms of your bearing surfaces or in the knee, whether or not you choose to fix them to the bone with cement or with an implant where the body can actually grow into it. That's kind of an emerging area also to see who are those, what type of implants really work best in that younger patient.
What would you tell the person whose hips and knees are great right now and they want to stay that way? How should we treat our bodies to avoid leading to a hip or knee replacement?
So my mentor in fellowship, Nagini, he used to have a saying. He said, nobody over 40 should be running.
Oh, no.
So he said, and now there is a little bit of data that's come out that says, well, maybe running wasn't quite as bad, but we know that the loads that you put on your joints when you run, they're about 5 to 6 times your body weight, and it's the repetitive impact that seems to not be beneficial for your joints. So I would say,
it makes sense.
If you're a runner, you know, the best thing is staying active. So if you're a runner and you love to run, I mean, you know, keep running. But if you could make yourself switch to something like a bike or swimming or doing some of these mini triathlons that some of the endurance runners, that's what we try to get them to switch over to. But really it's just about being active. Your joints like to move. They like it when the muscles around them are strong. I'm a big fan of these dynamic exercises where you strengthen and you move at the same time. So things like swimming, where you get the resistance of the water, that'll build some muscle up. Things like stationary bikes or even regular bikes, and then elliptical trainers, I think are all really good. They're good workouts for both the hips and the knees.
Okay, good information. I'm gonna take it to heart. We have Deborah on the line. Deborah, are you with me?
Yes.
Hi there. We're running against the clock, so go ahead and ask your question. We may have to answer it after the commercial break, but if you can be quick, that'd be great.
Yes, like I was explaining to the lady, I'm 55 years old. I've had 3 orthoscopic knee surgeries. One is bone on bone. One now is lower cartilage. I can't do cortisone shots because they don't help. And I'm diabetic, so what am I to do?
Okay.
Okay. So diabetes in and of itself is not a contraindication to having a knee replacement. And I think that's something that we have to understand. Again, with this being a quality of life surgery, it is something that we all have to just be on the same page with what the risks are. And the risks in a patient that has diabetes that's really well controlled, your risks aren't that much worse than a standard patient. So we don't need to withhold that joint replacement from them as long as they understand maybe they have a slightly higher risk for infection. If they're willing to take that risk and we can modify it as best we can, if we can get their blood sugar a little more well controlled and get it back down to a normal level, they have very good outcomes. And there's some different things we can do as surgeons to try to help with that.
Good deal. Deborah, I'm glad we got in your call. We're going to take a quick break and we're coming right back.
This is a Storm 5 HD weather update. Sign up for Weather Call at newschannel5.com.
Widespread freeze and frost conditions across Tennessee and Kentucky this morning gave way to a really beautiful day. Sunshine, blue skies, temperatures climbing into the 50s and 60s across the area because we've had enough cold nights, cold enough to prompt freeze and frost conditions. We won't have any more freeze or frost advisories issued until spring of next year. That doesn't mean it's not going to be a cold night. It just means the damage has been done to the growing season. Here's a look at temperatures across the southeast and, of course, current conditions right here in Nashville. Overnight tonight, we dropped down to 39, so not quite as cold as it was Monday morning, but that's still plenty brisk. Cooler than that outside the city, down to mid-30s in some spots. Tuesday looks mild and barely so. We'll have cloudy skies, temperatures in the upper 50s. Things look good for trick-or-treaters, a little cool with the extra cloud cover. Then rain will work in overnight Tuesday. By Wednesday morning, we'll have scattered showers across the area.
You get hurt, you know what to do.
Call Hughes and Coleman.
Call 800-800-4600. All you do is call.
And they take care of everything.
800-800-4600.
800-800-4600.
That's an easy number.
Studies show people who call a lawyer on average get up to 3 times more money.
That's a lot of moolah.
800-800-4600.
Hughes and Coleman. 800-800-4600.
Welcome to Ellen's Halloween Show.
Are you scared? Because you should be.
With tricks for Julie Bowen.
I don't want you to get mad.
Plus, an amazing treat for the eyes. And what Ellen will be this year is the biggest surprise.
You know what Andy is going to be for Halloween? Scared.
Tomorrow at 3 on News Channel 5.
If you would like to get a hold of Dr. Sandberg, real easy to do. Easiest way, call the number 615-996. 986. I can't read it from here. 6033. 986-6033. Say, I want to talk to the hip and knee guy, Dr. Sandberg, and they will get you in touch with him. And you can go in and see Dr. Sandberg. Thank you for being here
Thank you.
shedding so much light on this. I think we've learned a lot in the last hour. I appreciate it.
Yeah.
All right, go ahead and give him a call, or you can email him. You saw that address on the screen as well. Have a great night, everybody. We'll see you back here next Monday.